C- Can we have the slides up maybe because it's 6 minutes past the hour?
Yeah, just a second. I'm projecting them. Seba will be presenting. I'll be moving the slides.
Okay.
Yeah.
So, good evening, everyone.
Good evening, Seba. How are you?
Yeah, I'm fine, Dr. Joseph. I hope all is well.
Yeah. Well, I'm hoping to learn a lot from you today.
Yes, so today I'll be presenting to you a real case scenario of one of the patients that I happened to meet in our wards. So today's Aphrodite's case will be about a 61 years old female who initially presented with abdominal pain for 8 months. Then 4 months later, she developed passage of loose stool, and just 2 weeks before admission, she had lower limb swelling, unilateral lower limb swelling.
Unilateral.
Yes.
Okay. Yeah. Thank you very much. I love it when it is Sunday because we have this very important thing. To start with, you look at this case, just the chief complaint, you realize this is a chronic illness. This is a chronic illness. And the most striking things among these is the abdominal pain and loose stool. The loose stool also is chronic. So you have abdominal pain and diarrhea. Unilateral lower limb swelling, I think I'll put it aside before thinking of abdominal pain with diarrhea, with the chronic diarrhea. And then if you have abdominal pain, it depends with, you ask what's the region, but that's just a way of trying to remember stuff. Uh, if you working in the clinic or you're seeing patients in the ward, you realize someone presents and they have abdominal pain, a site that's not written in the book. So we divide them into those four quadrants, and depending on which organ is sitting below that organ, we try to think of the effect um, of the disease on that organ so that we can come up with the possibilities of what is troubling our patients. But there are things that cut across in the abdomen. Imagine small bowel, large bowel, and vessels. This can be anywhere. So in the history, Seba will tell us where's the abdominal pain. We're trying to think of the location and come up with a bit of diagnosis. But keeping in mind that's a way of remembering, anything is possible. But loose stool for 4 months qualifies this problem a bit differently. If it is stood alone abdominal pain, it's so different if someone says it's abdominal pain plus chronic diarrhea. And when you have chronic diarrhea, you have it's like three things that we can come up with, and these include chronic infections like TB of the intestine. Another is inflammation. Think of IBD probably, and then the other one might be malignancy. There are others. There are others that can also be there, and I think I'm just moving fast. But if you pause, you can think of inflammatory and non-inflammatory chronic diarrheas. They have their differential diagnosis, which we can talk about later. So swelling, Seba said this early on that is unilateral. It's so different. But even if it's unilateral, I would want to know which is the leg that is affected by lower limb swelling. Some diseases that will present with bilateral lower limb swelling, they can start with the unilateral lower limb swelling, which is usually the left side, based on how the vessels supplying those limbs are sitting in the pelvis. So patients with heart failure can have left leg swelling, later on they have uh, bilateral lower limb swelling. But if it's strictly unilateral lower limb swelling, the first question to ask is it a vessel that is blocked, or is it a lymph node that is blocked, such that we have swelling in just one limb and not involving the other? Yeah, so I think I should listen to the HPI and see if I can progress. Thank you.
So the abdominal pain was gradual onset, so it was experienced in the epigastric area, burning in nature, so it was of intermittent, moderate pain score radiating to the back, so it was more pronounced after meals intake, exacerbated by lying flat or lying to the right side, and usually it could be relieved by sitting upright. So it was associated with bloating, belching, and regurgitation of the recently eaten food accompanied by a sour or acidic taste, together with nausea with no vomiting. So there was history of mild weight loss of only about 4 kgs in the time frame of 8 months. So it was not associated with early satiety, loss of appetite, generalized body weakness, a report of throat irritation, cough, hoarseness of voice, or choking while feeding. So there's no history of oral ulceration, difficult or painful swallowing, passage of black tarry stool or vomiting blood, awakening at night due to abdominal pain, yes, discoloration of the eyes, palms, soles, or skin, easy bleeding tendencies, body itching, or awareness of heartbeat or exhaustion with physical activities. So the passage of loose stool for 4 months was gradual onset, intermittent, non-blood, watery consistence with no solid pieces, not foul smelling. So the patient reports an average of about 6 to 8 motions per day, but in some days she could go up to 10 motions per day. So she reports to be of large volume and more at night and early in the morning, aggravated by spicy, fried or fat foods intake, so it was not relieved by fasting or sleep. She reports this was associated with sudden involuntary low abdominal cramps and a strong uncontrollable desire to defecate, together with, at times, inability to hold stool. So it was not associated with passage of bulky grease, clay-colored foul-smelling stool, perianal skin itching or excoriation, or intake of gluten-containing food, or intake of dairy products. So coming back to the lower limb, it was of gradual onset, progressive, painful, aggravated by prolonged standing with minimal relief with leg elevation. It was associated with reddening of the affected limb. There was no history of shortness of breath, chest tightness or chest pain, joint pain or swelling, eye pain, redness, tearing, or increased sensitivity to light. So there was not any history of recent travel or trauma to the left lower limb. And then there is no any other member in the family that was passing loose stool. No reported history of intake of contaminated food, water, or salad, consumption of unpasteurized milk, alcohol intake, or cigarettes, previous abdominal surgery, no prior history of use of antibiotics, NSAIDs or biphosphonates. There is not any reported history of ingestion of corrosive, but there is a positive history of use of drugs, which was PPI, together with antibiotics, that is metronidazole, after the onset of the abdominal pain. But prior to the abdominal pain, there is not any reported uses of drugs. So there is no history of previous TB or known open tuberculosis contacts. There is no history of genital ulcer, previous history of genital urinary discharge, heat or cold intolerance, hyperpigmentation of the palms or sores, skin lesion, dry eyes or mouth, or increased sensitivity to light. Yes, back to you, Dr. Joseph.
Yeah, that's an exhaustive history. And if I'm to be honest, I can say I'm trying to think and linking stuff in my head, but hard to come up with one thing that I can work on. And that's the normal situation to find yourself when solving a case. So we will dissect it bite by bite and see if these isolated information can be joined and whether they make sense as regard to what I know based on this history and this chief complaint HPI. So if I start to solve chronic abdominal pain, luckily we are told that this is localized. It's localized on the epigastrium. And then you think, what sits in the epigastrium? One is the stomach itself, but there are other stuff. Of importance also include the pancreas. But again, the transverse colon traverses around there. But some patients, as I said initially, these are just ways to remember the DDX to abdominal pain, but it doesn't mean it's a strict rule to be followed. So someone can have hepatobiliary diseases and they can have epigastric pain. I've seen that. So if I see any suspicious thing in the history, I'm not ruling out other possibilities of abdominal pain that doesn't localize on the epigastrium. But to solve this strict localization first, what are the diseases that can affect the chronic diseases that can affect the stomach? We all know of peptic ulcer disease. But if you see a patient with peptic ulcer disease, the presentation shouldn't be like this. If you're seeing someone, they have peptic ulcer disease, and then somebody's telling you they're losing weight, you start to be suspicious that, okay, maybe this is not just peptic ulcer disease. You start thinking of other possibilities, which includes things like stomach malignancy, probably. Other diagnoses include GERD, but these are just uh, cannot present like this. The way I'm hearing this picture, it has to be something more serious than, more sinister than these minimal diagnosis. So, how about the pancreas? The pancreas here is so important because one, the characteristic, apart from this pain being localized on the epigastrium, it also adheres to the back. So, are we probably dealing with chronic pancreatitis? And the answer is more likely because look at other supporting features, uh, such as radiating to the back, more pronounced after meal intake. So anything, a meal a meal to the GI system is like exercise to the heart. So if I have coronary artery disease, I try to exercise, I feel pain. The same applies when you have um, a GI disease and you give it a meal, the pain, you exacerbate the pain, which means either there is a blockage of blood supply into your GI system, or there is a problem with secretions of the juices that should happen when you eat. I'm not seeing anything else suggesting maybe this is a problem of vascular supply of the GI. But if I think of the epigastrium, think of the pancreas, and then this more being more pronounced at the meal intake, localizes it more and more to the to the pancreas. But I don't want to anchor early on here. But that's the thought that I'm keeping in. Probably we're dealing with chronic pancreatitis, and then I'll see how I progress here. Can I see the next slide? Yeah. So both bloating, belching, regurgitation, now the vomiting. Of most importance is an intentional weight loss. You know, when you have chronic abdominal pain with chronic diarrhea, and then you have weight loss, this is a red flag. This is a red flag, and it can tell you because of abdominal because of unintentional weight loss, probably you are dealing with an inflammatory disease, but probably it's not. If you think of the pancreas, it makes very important juices for the absorption of nutrients at the end. So if you have a problem with the pancreas, you can also lose weight, even if you don't have the inflammatory disease of the GI. And next, okay, next slide. Okay, next slide. Uh-huh. Yeah, so loose stool is, as I said initially, qualifies more this abdominal pain. So if you have chronic, this is a chronic diarrhea. That's what I will be solving here. Loose stool for 4 months, chronic diarrhea, which is a passage of it's a diarrhea of which takes more than 4 weeks. So if you have this kind of diarrhea, you ask yourself, is it inflammatory or non-inflammatory? Here it will be hard because the things that characterize inflammatory diarrhea includes probably abdominal pain, which is there, plus weight loss, which is also there, plus blood in stool, which is not there, fever, it's not there. So these two things, abdominal pain, and we already have suspicion that probably the patient is having chronic pancreatitis, which can also cause abdominal pain. And chronic pancreatitis can't be just inflammatory. It can also be non-inflammatory. The other is the weight loss. Again, I've said if there is a problem with the pancreas, this patient might not absorb the nutrients and lose weight, but doesn't necessarily mean they have a problem. They have an inflammation of the inflammatory diarrhea, because think of the patient with probably exocrine pancreatic insufficiency. It doesn't necessarily have to be inflammatory. It can be non-inflammatory, and then this patient can present with that. So I think with all the information that I have, I believe we have to localize this disease on the pancreas. Everything points out there, from the epigastric abdominal pain, radiating to the back, weight loss, and diarrhea of chronic duration. So Can I see the next slides? Yeah. Now this one is here is hard for me to connect with what I've already said, because you hear a story like this, everyone, when you read I think these are the tumors of the colons, you are told of tenesmus, and this is something that sounds like it. But is it? Should we go there? Because we haven't been talking about anything else that tries to localize the disease the to the colons. That says this is the patient that have the urge to defecate and ability to hold stool. Another explanation that comes in my mind quickly, but I haven't checked it. Uh, Probably there are things that irritates the colon of these patients, and they have something that looks like a tenesmus. So I don't think that I will localize this disease to the colon just because of this slide, but I can say we can have a problem with the pancreas. We can have an an irritant that goes to the colon and creates a picture like this. And I think from there we should proceed. Uh-huh. Yeah, okay, there is still a lot to discuss here. So um Seba is telling us it's not associated with bulky, greasy, clay colored false smelling stool. Yeah, if I'm saying chronic pancreatitis, but telling myself not to anchor early on in this case, because things like greasy stool, these are the ones that you see in pancreatitis, but it is not there. Does it tell me to move away from that diagnosis? I think it's too early to say, and I have to see other stuff in this case so that I can think more clearly. Yeah, next slide.
Joseph, is there? Okay, next slide. Yeah, lower limb swelling.
Yeah. So as I said initially, unilateral limb swelling is the swelling coming from the vessel, or is there blockage at the lymph node that is causing the swelling of just one limb and not the other? Um, if I should be honest here, I cannot tell for sure what is this limb swelling, especially with the next slide. There is something about the color. Yes, associated with reddening of the affected limb. I'm not so sure what that this mean, to be honest.
Uh,
But reddening,
I'm not sure. Is everyone else able to hear Joseph clearly? Joseph, I feel like you're breaking. I'm not sure if it's my internet.
uh-huh. Okay, how about that?
Yes, I think we can hear you, Dr. Joseph.
Okay, let me move my internet to the better spot. So now you can hear me well, eh?
Yes, yes.
Yeah, it's clear. I hope you think so.
Yeah, so I was trying to say I'm not so sure what this lower limb swelling, um, which is associated with reddening of the affected limb entails. But trying to think as we do here, red means more blood. So is it that the vessels, because I said, it says that the vessel or the lymph node, we're not seeing anything that's telling us about the lymph node. We'll see that in the physical exam, but probably it's a vessel. When you stand, because of the gravity, blood pulls in on your limbs, But why should it pull more in one limb more than the other? Maybe the vessels of this limb are more dilated than the other. So if I connect this left lower limb swelling that's associated with the leadening of the affected limb with all that we are talking from initially, I don't know to make of this, but I think I should chill and wait for more juicy from this case of that Seba is presenting today, and see if I can come up with anything. Thank you, Seba. I think we should proceed.
Yes, thank you, Dr. Joseph. So in the review of other system, it was unremarkable. Past medical history was also unremarkable. So the patient has a strong familial history of diabetes mellitus type 2, with more than 4 of his family members being affected by diabetes mellitus. Also, there is a history of a number of autoimmune diseases in the family, like rheumatoid arthritis.
Okay, should I discuss that? Okay, yeah, sure. So, this family and social history is the patient female or male? Sorry, it's female, right?
She's female.
Yes,
Yes.
that's very good. So, uh, I'll I'll say something on the strong family history of autoimmune disease. So the DM itself that the family is having might be autoimmune, which means it's not type 2. It says type 1 or other types. And then the other family members having different autoimmune diseases, there is a percent of these autoimmune diseases that you've mentioned to have a genetic component. So probably we are dealing with an autoimmune disease that is presenting with all these. I'm putting that on my back pocket. I'll see later if anything comes to me. But as of now, I cannot think of any autoimmune disease that might give all these presentations. So I think we should proceed with the exam.
So in the general examination, our patient was fully conscious, febrile, not pale, not jaundiced, not dehydrated, no oral thrush, there was no aphthous ulcers, no angular stomatitis. So there are no any stigmatas for pancreatic diseases like the gray Turner or the Cullen sign. Our patient had erythematous lower limb edema, which was pitting, with a positive hormone sign, with no palpable peripheral lymph nodes. The stigmatas for chronic liver or kidney disease were absent in our patient. So the vitals were fairly normal, but our patient had an elevated BMI. She was obese, the BMI of 33, and RBG was also elevated with a hyperglycemia of 11.5. So in per abdomen systemic examination, per abdomen, our patient had an obese abdomen. Apart from that, there was no any positive finding. So the other systemic examination were also fairly normal.
Hello?
Yes, Dr. Joseph.
Can you hear me?
Yes, we can hear you.
Okay. Yeah, so that's the exam, eh?
Yes.
Yeah. Um, this is a challenging case to me because up to now I don't have any trying to search in my brain, but I cannot connect stuff right now. So let me see if I can progress. One thing that still eludes me, and I think it's a cornerstone to this diagnosis, is to make what is that lower limb swelling with erythema. So that's more. It's very important. That's a gap to me, and I realize if I can tackle that, I can connect with the two things that at least I know because I've been seeing them and make a diagnosis. So of importance, you've told me in the general exam there are no nodes, especially in the left inguinal region of this patient. If there are nodes, they could point out why this patient has a swollen limb. There are no nodes, and then the limb is swollen, just not just swollen, but it's also red. And to me, as I said, a red swollen limb is a lot of blood in that limb. Why should there be a lot of blood in just one limb? That I cannot tell. But let me go back and recollect this case and see if I can make progress in any way before receiving the labs or probably imaging. So where I am now, if I connect the chronic diarrhea is more important in this case than the abdominal pain. And I've said the chronic diarrhea, I say that you have inflammatory or non-inflammatory. It's hard to tell if this patient is inflammatory or non-inflammatory because both of the things are there. Uh, so I'm still thinking this patient has chronic pancreatitis, but I am not seeing anyhow. And the history of DM also points that direction, but I'm still not seeing how does the chronic pancreatitis would explain that erythema and swelling of the left lower limb. Other diagnoses includes secretions of some hormones, secretions of some hormones that can cause secretory diarrhea. Secretory diarrhea. So these are very rare, and if to be honest, I've never seen a case. It's only that I can remember that I've read things like VI pioma, and then there is another one. But again, it's not that flavor. These things, they have systemic symptoms because these hormones are just secreted. They're flushing of the whole face, these patients, but not flushing of just the limb. So I think, Seba, to be honest with you, if I have a case like this up to now, I'll be opening open evidence and chat GPT and up to date to read what is happening. So let's proceed. I shouldn't waste your time because I have nothing more important to say.
Okay, thank you, Dr. Joseph. So moving on to the investigations. So CBC was done to this patient, and CBC had normal parameters. So baseline investigations like the renal function test, the liver enzymes, and other liver synthetic functions were also within normal range. So stool analysis revealed no ova or cyst, but there was presence of 30 RBCs per HPF. So we went ahead and did a stool culture in a time frame of 72 hours. So there was not any growth. Serology was done to this patient and was HIV was negative, and other viral hepatitis were negative. Thyroid profile was normal. ANA was done to this patient, which was negative. Patient had normal ESR levels, smidge elevated CRP of about 12.8, but significantly elevated fecal calciprotectin levels of about 364. So we also went ahead and tested for serum lipase and amylase levels, which were all within the normal limits. And we also investigated further for serum antiglutaminase IgA, which was negative. Our patient had significantly elevated D-dimer levels of about 12,800. So OGD was done to this patient, which showed an upward displacement of the gastroesophageal junction about 2 centimeters above the diaphragmatic hiatus. loose lower esophageal sphincter. So the conclusion was gastroesophageal reflux disease. So colonoscopy was also done to this patient, which had normal colonoscopic findings. So we went ahead and performed the abdominopelvic CT scan, which also revealed normal findings. So Doppler ultrasound of the left lower limb revealed an acute DVT in the left lower extremity. So maybe Dr. Joseph, you can comment
Yeah,
on these investigations before we switch further.
I should comment. Can you go back to that, the last slide? Yeah, okay. Did you guys do HIV in this patient?
Yes, yes. So serology was done, which was negative.
Yeah, good.
HIV ELISA was negative.
Good. Yeah, so I can try to make some progress here because I had, for example, some difficulties telling is this inflammatory or non-inflammatory diarrhea. If you're telling me this information, now I can shift my attention to just one of the categories. So we are seeing blood in these in the stool of these patients, and again we are seeing a very high elevated CRP, a highly elevated calprotectin level, and a high D-dimer. So all these points to the possibility that this is an inflammatory disease. It is not just a non-inflammatory disease. This is an inflammatory disease. So for me, to make matters easy, if I have a patient with chronic diarrhea, on one end I have non-inflammatory, on the other end I have inflammatory, I can go through inflammatory diarrhea and see if I happen to alive the diagnosis of this patient. But before that, the D-dimer is not elevated just because this patient is inflamed. The rim reddening that we are being told with a positive Hoffman, which means when you suddenly flex the anchor joint, they feel pain. Usually not done nowadays, by the way. We're told the patient have DVT. So I'll tackle DVT later, but still currently, right now, let me talk about inflammatory diarrhea. So what are the differential diagnoses? Inflammation, we talk here every day. Infections, autoimmunities, cancer. Let's start with autoimmune. We have IBD as the most common autoimmune disease that we know in the GI. But look at this case. Seba has already given us even the colonoscopy. They're not seeing anything there. And even in the other part of the GI, like the oral mucosa, it's normal. So probably it's not IBD because we haven't seen anything. Another is malignancy. So colon malignancy, lymphoma, these can cause also chronic inflammatory diarrhea, but there is no that flavor that this patient is having malignancy. We're remaining with one thing, which is infectious causes. So are we dealing with the infections of the GI, the chronic infections of the GI? The answer is not straightforward because infections to be chronic like this, they have to be very atypical in an immunocompetent person. If that's why I asked about HIV. If it was HIV positive, you can have some viral infections that persist in this patient, like CMV. But in an immunocompetent like this patient, to have chronic infections of the GI causing diarrhea, abdominal pain for this long, that has to be so atypical. And in this region, you must talk about TB. So are we dealing with intestinal TB in these patients? That is also hard because if you get in a colonoscopy, you can see some lesions that you can biopsy them and tell if it's TB. But if it's GI TB, why should it have epigastric abdominal pain? But having said that, you can still not rule that out, because something else was identified when they did an upper endoscopy. They saw this patient also has GERD. So we usually say medical parsimony, connect all the symptoms, come up with one diagnosis. But what if it's not true? What if the upper abdominal pain is not related? We should just be dealing with inflammatory diarrhea in this patient, treat GERD as usual initially, and then separate it from chronic inflammatory diarrhea, find the diagnosis for chronic inflammatory diarrhea. If that's the case, uh, probably TB can stand. And then other diagnoses, parasites, hard to tell. Maybe intestinal schistosomiasis can't present like this. So the other thing is the DVT. Should you also connect? So a lot of things not cannot be just easily connected here. This patient has a DVT. Is it just an isolated finding? A patient in this age can have a DVT and it's not related. But what if it's connected? So to me, if you have a DVT, if I want to connect it with anything, because when you're seeing this patient and you're asking yourself, maybe we have to treat the DVT, you have to ask, is there an underlying problem that's causing the hypercoagulability, or is just there was a transient thing like prolonged sitting that caused this? And ask that in a patient with 60 years or 60 something years of age, you should ask about yourself if they have malignancy. Because malignancy is in a hypercoagulable state. And I'm asking myself, malignancy of which area of these patients? Is this the pancreas? I'm not seeing anything else apart from these symptoms that are directing me that probably this patient is having malignancy of their pancreas. So, Seba, I'm not sure what to say. My mind right now is on the part that says this is the chronic inflammatory diarrhea, image negative. Everything is just negative. And is there something that we are missing out? An infection, or I'm not sure. Is there any other
Yes. So
history? Or we should.
yes, yes. So in a 60 years old female like this one here presenting with DVT, we went ahead and thoroughly investigated for a possibility of presence of occult malignancies, which may not present with obvious clinical symptoms. So chest X-ray was done to this patient, which was normal. Breast ultrasound was normal, and the abdominal pelvic CT scan that we had done previously also was normal. Yes. So, is there any extra investigation that you can should come onto your mind, Dr. David, Dr. Joseph?
Um. Yeah. So let me think. You mean you tried to rule out occult malignancies, but there was no possibilities, right?
Joseph, if you are trying
Ah,
to speak, you are
okay.
muted.
Yeah, sorry, I think I was muted. I'm saying what I understood from that, you said you tried to rule out some occult malignancies, but you couldn't see any, right?
Yes, yes.
Okay. Yeah, so let me see.
So, would you go ahead and biopsy
Yes, that's definitely.
the
I must have,
normal
because
colon in this patient?
yes, I must, because so okay. This is hard. First of all, I appreciate that, but I'm on very hot seat, and I'm trying to think here. There is this category of if you have, because if you have abdominal pain, most commonly imaging will be able to delineate the diagnosis. Most commonly, you do imaging, you have the diagnosis. So we have done imaging here, colonoscopy, upper and lower endoscopies, done the CT with contrast, and then we don't have a diagnosis. Should we term this image negative abdominal pain, with diarrhea, or is there an imaging modality that we haven't done? And the answer is we haven't done one imaging here, which is uh, um, I think it's the angio of the GI. But again, the angio of the GI is for some diagnosis like um, some diagnosis like clots that are present in the vasculatures of the blood supply of the intestines. I'm not seeing the flavor in this patient because those patients will have abdominal pain after eating, but they shouldn't have diarrhea. So I don't think if that's the case. And then there are no other risk factors. This patient will usually have other vascular diseases like they have AFib, for example. So I'm not thinking if I do angio of the GI, I can come up with anything because it doesn't tally. Now, another thing in that category, which, to be honest, I'll open my internet and search a schema for that. And uh, to biopsy, yes, I must biopsy because some things you cannot see them, but you can see on just biopsy. So in front of me, I've just googled here the CP solver schema for image negative abdominal pain, and I'm trying to see all the other things like DKA. They're not making sense. IBS, this can't be IBS, but there was a category here written other. Uh, One thing that makes it can be seen when you do biopsy, but you cannot see them when you do other imaging. Is this eosinophilic gastroenteritis? Probably this. So uh, yes, I must biopsy, and one of the targets can be this that I've read in this schema of this CP solver. I don't know what you did, but yeah, I should learn from you, Seba.
Yeah, so this patient was attended by a very brilliant gastroenterologist team. So despite having normal colonoscopic findings, actually more than 2 different times, colonoscopy, she underwent colonoscopy 2 different times by 2 different very experienced gastroenterologists. So after having all of them, the results came out to be a normal colonoscopic findings. So an extra initiative was taken to biopsy despite normal, having a normal gross anatomy. So a colon mucosa biopsy was done to this patient, which revealed chronic colitis with focal epithelial atypia.
Okay.
Should I move the slide, Seba?
Yes, maybe Dr. Joseph, does this maybe ring anything onto your mind in terms of what could be the possible diagnosis in this patient?
Yeah. When I see something like
Because you're moving in a very right direction from the clinical approach. You ended up with a chronic inflammatory diarrhea
yeah,
of
yeah. So chronic inflammatory diarrhea, I say the autoimmune infection, malignancy is probably out. Infections not so likely. TB of the intestine, we should have seen something. Yeah, so autoimmune, with the autoimmune history in the family, probably most. And when you talk about autoimmune, we talk about IBD without something to see. Yes, I understand it is possible, but I don't think if I can make that diagnosis when I'm seeing the patient. So yeah,
yes. Thank you,
IBD
Dr.
very
Joseph.
possible.
Yes.
So is this where, do I move the slide, or is this where Joseph commits to a particular diagnosis?
Yes, I think this is the point where he commits.
Yeah, so I can say inflammatory bowel disease. if I say inflammatory bowel disease, it's just this because is there any other thing I don't know, but yeah, I think I can say IBD.
Maybe what type of IBD? Is it
Ah,
the common IBD that we have frequently, or there could be another subtype which is usually under the radar most of the times?
oh, apart from describing them as ulcerative colitis and CD.
Yes.
Ah, no, that I'm not. That I'm not. I don't know. You have to teach me, Seba.
So yes, I think Dr. David, you can move. So yes, Dr. Joseph, you are very right all along the way. So our final diagnosis in our patient was an inflammatory colitis, which was IBD, specifically the so-called microscopic colitis, presenting with venous thromboembolism, which was DVT in the left lower limb,
Mm.
together with hiatohernia with gastroesophageal reflux disease. So yes, some few learning points, specifically in the parts of an approach to chronic diarrhea in this postmenopausal age of 61 years of age. So what we can appreciate and what has been strongly said by Dr. Joseph, we're dealing with the chronic diarrhea, and some of the causes were ruled out effectively from the initial aspects of our history, features like lactose intolerance. Our patient did not have diarrhea, which was affected when she takes dairy products or any gluten containing products did not exacerbate or increase the extent in which she got diarrhea. So in most of the time, by that we could be able to rule out presence of either celiac disease or the possibility of having lactose intolerance. So irritable bowel disease is usually from the latest criteria, if a patient having age more than 50, and this patient had typical nocturnal diarrhea. So usually presence of irritable bowel syndrome, one of the criteria that rules out the possibility of having IBD is the presence of nocturnal diarrhea. So our patient had a typical nocturnal diarrhea together with an early morning vis-a-vis presence of the daytime diarrhea. Parasitic infection also very common, but stool analysis did not show any evidence of an ova or cyst. Medications use, yes. So after our patient had a prior history of abdominal pain, she was kept on the use of medications which were PPI together with metronidazole. So this also can explain some sort of cause of chronic diarrhea, like the small intestinal bacterial overgrowth, and also even a possibility of pseudomembranous colitis. So that is also a very important points of differential when we are having chronic diarrhea. So we went ahead to see if this is an inflammatory or a non-inflammatory diarrhea. So as Dr. Joseph cited out correctly, presence of an abdominal pain, and also a patient had presence of blood in stool. Sometimes blood may not be very obvious until you perform a stool analysis or an all-cut blood test. So a patient had an all-cut blood with the presence of 30 RBCs. So this pointed automatically into the presence of inflammatory diarrhea. In the part of inflammatory diarrhea, most of the common causes is inflammatory bowel disease together with neoplasms. For the inflammatory bowel disease, we have three major types, but the ones which are usually very common and heavily mentioned is ulcerative colitis, which presents with gross blood diarrhea together with an inflammatory Crohn's disease. And also the third type, which is usually not very common, is what is known as a microscopic colitis, in which patient present with non-blood watery diarrhea. So Microscopic colitis, this is the chronic inflammatory disease of the colon that is characterized by a presence of chronic intermittent water diarrhea, non-blood. So most of the patients, up to 70%, usually they have an associated fecal urgens and fecal incontinence. So they also have abdominal pain and nocturnal periodicity. So it's usually, it has a female preponderance in a ratio of about 3:1. And the mean age in which patients develop microscopic colitis is usually about 60 to 65 years, and our patient was 61 years. So there are some of the risk factors that have been associated: use of the medications and also smoking. So in microscopic colitis, there are four major key areas of pathophysiological processes. So there is a genetic component in it. Then there is a part of a gut microbiome dysbiosis. And then there is a part of autoimmunity in it. And also, these patients also may present with bile acid malabsorption, together with an element of protein losing enteropathy. So there are two major types. It can be a lymphocytic colitis or collagenous colitis. All of these are histological findings. So despite microscopic colitis being under the radar, it has a prevalence close to that of other IBDs, particularly in the elderly, starting from the sixth decade of life. So unlike ulcerative colitis or Crohn's disease, microscopic colitis typically presents with a normal appearing colon, which requires deep mucosa biopsy for diagnosis. And of very huge importance in this patient, as we saw in our patients, the ESR was within normal range. CRP was slightly elevated of about 12, but when we did the fecal calciprotectin, which is the measure, the investigation which typically depicts inflammation going on in the colon, so colonic inflammation. So in terms of the systemic picture, ESR was within normal range, CRP slightly elevated. So systemic inflammation is not a very typical feature, but rather an isolated colonic inflammation. So the 364 levels of fecal calciprotectin, this anything above 250 of calciprotectin depicts a severe colonic inflammation. So usually present with an epithelial tipia or low subtle and may indicate a long-standing inflammatory insult and requires long-term surveillance due to its potential dysplastic implications. So coming to the management of microscopic colitis, usually the preferred first line of treatment is the presence of an oral steroid. And the oral steroid which is preferred is the one which has maintains very good gut concentration with very less systemic side effects. The gold standard is budesonide, but budesonide usually, oral form of budesonide is very difficult to get, especially in our setting. So we tend to use what is known as the steroid equivalent. So steroid equivalent, we can go ahead and use oral prednisone, although prednisone is associated with more systemic side effects in comparison to budesonide. So usually 9 milligram daily for 6 to 8 weeks until you attain clinical response in this patient. You can also give some other medications such as loperamide and cholestyramine for those patients who may present with bile acid malabsorption. So maybe Dr. David, maybe we can move to the next slide. So I think there's a slide before that one. Okay, I think it's... So in areas where we don't have budesonide, the preferred first line of treatment, we use prednisone. But in our patient, after we initiated her in prednisone, she got very severe nausea and vomiting, and she was not able to tolerate prednisone. So we went on to another steroid equivalent for prednisone, which was we kept on IV dexamethasone for 5 days. Then after that, we initiated our patient on azathioprine. So currently she's on azathioprine, and since after we started her on steroids, this is the second week. The motions, she has not experienced any motions. This is the second week after we have initiated her on dexamethasone. Then now she's on azathioprine. So in terms of clinical response can be monitored by a number of motions per day. So remission is defined as when the patient will be having less than 3 motions in 24 hours, but there is a biochemical response. Biochemical response is defined by the measurement of the fecal calciprotectin levels and comparing with the baseline fecal calciprotectin that we had. Histological response may be done, but is usually not routinely done. And also another important thing is to monitor for the possibility of azathioprine mediated toxicities, such as the agranulocytosis and the hepatic necrosis. So overall, microscopic colitis has a favorable prognosis, although this patient usually experience very high relapse rates of about 80% when they are off maintenance therapy. So there is no increased mortality in these patients, and symptoms may impair quality of life, but it does not increase the risk of colorectal cancer, and it has no association with long-term complications like colectomy, for example, in patients with chronic disease, Crohn's disease. Persistent of histological inflammation is not associated with poor outcomes. So in terms of what could explain the DVT in these patients, so a number of literatures, we went ahead when we were also seeing this patient, we're trying to see what could explain DVT in these patients. So we went ahead and dig through in the literature. We came out to find that there is a very strong association between having microscopic colitis and developing venous thromboembolism. So there is an increased percent of up to 21% in comparison to the general population in patients who have microscopic colitis to develop a deep venous thrombosis.
Yeah. Seba, as always, thank you very much. This is the purpose of why we are doing this. And so I came here with nothing, and I'm leaving from this conversation just an hour, and I have a lot of things. When you lead the topic of IBD, these things, even up to date, there is a category there. You're told about this. But, you have to be put in an environment like this. You're told someone has chronic inflammatory diarrhea, looks autoimmune, but all the endoscopies are normal. And the answer is just you should go on and take the biopsy no matter what. So this is a huge learning, and I believe will help me in the future when I see patients with chronic diarrhea that I believe is inflammatory, and then maybe most endoscopies in our hospitals just diagnostic. They put in, look, say nothing, go back. I believe that was also maybe the first endoscopist did. So if we are equipped with this kind of knowledge, we can discuss with those endoscopists. Say, there is this form of IBD that microscopic IBD that cannot be seen by your eyes. So thank you very much. I appreciate this learning.
Thank you very much, Joseph. So, we are past the hour, but if anyone has anything, please welcome. And in the meantime, I shared in the chat. So for those who have, we are trying to make sure that people who are joining frequently do not get any difficulties when it comes to getting hold of the link. So we've created a group where we share the link every Sunday morning, just to make sure that you can get the link early and join without missing if the one who is sending you always forgets. So I've shared a link in the chat. You can, for those who have not joined the group, you can join there, and you'll be getting the link every time we have a session. Yeah, so I see a hand from Zainab. Please welcome. I saw a hand. I'm not sure if that was accidental. If anyone has anything, please welcome before we close. Yeah, so I see no hands. It's been a very informative discussion. So Joseph, a meticulous approach to abdominal pain, diarrhea, and again making a lot of progress with all the symptoms in this patient was who had a very complex presentation, and Seba, very detailed teaching points. Thank you very much all for learning. So we hope to see you back next Sunday. We'll come back with other cases. Until then, have a good night.
Good night.